Do not use supplements as meal substitutes. Use them as snacks between meals. In long-term care, using these beverages instead of water for oral medication administration increases caloric intake. Enteral Nutrition. Enteral nutrition, EN, also known as tube feeding, is nutrition, e.g., a nutritionally balanced liquefied food or formula, delivered directly into the GI tract, bypassing the oral cavity. EN is used with the patient who has a functioning GI tract but is unable to take any or enough oral nourishment, or when it is unsafe to do so. Indications for EN include persons with anorexia, orofacial fractures, head and neck cancer, neurologic or psychiatric conditions that prevent oral intake, extensive burns, or critical illness, especially if mechanical ventilation is needed, and those receiving chemotherapy or radiation therapy. EN is easily administered, safer, more physiologically efficient, and less expensive than PN. There is a wide variety of enteral formulas. Their concentration, flavor, osmolality, and amounts of protein, sodium, and fat vary. There are special formulas for patients with diabetes and liver, kidney, or lung disease. Most are lactose-free. Concentrations range from 1 to 2 calories per milliliter. Most standard formulas provide between 1 and 1.5 calories per milliliter. The more calorically dense the formula, the less water it has. The number and size of particles in the formula determines its osmolality. The more hydrolyzed or broken down the nutrients, the greater the osmolality. A formula with a high sodium content is contraindicated in the patient with cardiovascular problems, such as heart failure. Those with short bowel syndrome or ileocecal resection should not receive one with a high fat content because of impaired fat absorption. Patients receiving EN with a protein content greater than 16% need supplemental fluids through the refeeding tube or by mouth, if permitted, to avoid dehydration. Common delivery options are continuous infusion of intermittent bolus feedings by infusion pump, bolus feedings by gravity, and bolus feedings by syringe. Critically ill patients often receive EN by continuous infusion. Bolus feeding may be an option if the patient improves or is receiving EN at home. We give EN via a tube, catheter, or stoma. The type of access depends on the 1. Anticipated length of time EN will be required, 2. Degree of risk for aspiration, 3. Patient's clinical status, 4. Adequacy of digestion and absorption, and 5. Patient's anatomy, e.g. extreme obesity. Figure 39.7 shows the locations of commonly used enteral feeding tubes. Orogastric, nasogastric, and nasointestinal tubes. Nasally and orally placed tubes, orogastric, nasogastric, NG, nasoduodenal, nasojejunal, are appropriate for short-term feeding, less than 4 weeks. Nasoduodenal and nasojejunal tubes are transpyloric tubes. They are used when pathophysiologic conditions call for feeding the patient below the pyloric sphincter. Placement into the small intestine decreases the chance of regurgitating gastric contents into the esophagus and aspiration. However, the patient can still aspirate gastric secretions if the stomach is not emptying properly. Polyurethane or silicone feeding tubes are long, small in diameter, soft, and flexible. The design decreases the risk for mucosal damage from prolonged placement. These tubes are radio-opaque, making their position readily identified by X-ray. A stylet is used for tube placement in a comatose patient because the ability to swallow is not essential during insertion. A complication that can result from using a stylet is increased risk for perforation. While smaller feeding tubes have many advantages over tubes with wider lumens, such as the standard decompression and G-tube, there are some disadvantages. Because of the small diameter and length, these tubes clog easily. They are harder to use for checking residual volumes. They are particularly prone to occlusion if you do not thoroughly crush and dissolve oral drugs before administration. Failure to flush the tubing before and after giving drugs or checking residual volume can cause tube occlusion. Vomiting or coughing can dislodge the tubes. They can become knotted or kinked. Problems with the tube may require removal and insertion of a new tube, which adds to cost and patient discomfort. Gastrostomy and Jejunostomy tubes. If feedings are needed for an extended time, tubes can be placed in the stomach, gastrostomy, or small bowel, jejunostomy. A gastrostomy tube can be placed surgically, radiologically, or endoscopically. The patient must have an intact, unobstructed GI tract. The esophageal lumen must be wide enough to pass the endoscope for percutaneous endoscopic gastrostomy, PEG, tube placement. PEG tube and radiologically placed gastrostomy tube procedures have fewer risks than surgical placement. The procedure requires IV sedation and local anesthesia. IV antibiotics are given before the procedure. For the patient with chronic reflux, feeding through a jejunostomy J-tube may be necessary to reduce the risk for aspiration. Jejunostomy tubes are placed either endoscopically or with open or laparoscopic surgery. Combination gastrojejunostomy GJ tubes allow for simultaneous gastric decompression and small bowel feeding. When a patient has a GJ tube, it is important to know which port is the gastric and which is the jejunal. The tube is either pre-marked or marked at the skin insertion site. Enteral feedings can start within 24 hours after a surgically placed gastrostomy or jejunostomy tube without waiting for flatus or a bowel movement. Most other PEG tube feedings can start within 4 hours of insertion, although agency policies may vary. EN and safety. You have a critical role in ensuring that EN is administered safely. Aspiration and dislodged tubes are important safety concerns. Nursing management of enteral feeding is addressed in Table 39.11. Accidental tube removal can result in delayed feedings and potential discomfort with tube replacement. The management of common problems in patients receiving EN is outlined in Table 39.12. A nursing care plan for the patient receiving EN is available on the website for this chapter. Specific care and teaching related to feeding tubes and EN are discussed in the following section. Remember that it is important to teach the patient and caregiver how to care for the feeding tube and properly administer EN. Aspiration risk. Evaluate all enterally fed patients for risk for aspiration. Before starting feedings, ensure the tube is in the right position. Proper patient positioning decreases the risk for aspiration. To prevent aspiration, always keep the head of the bed elevated 30 to 45 degrees. If the patient does not tolerate a backrest elevation, use a reverse Trendelenburg position to elevate the head of the bed unless contraindicated. If you need to lower the head of the bed for a procedure, quickly returning the patient to at least 30 degrees is critical. Follow agency policy for suspending feeding while the patient is supine. With bolus feedings, the head should remain elevated for 30 to 60 minutes after feeding. There's much disagreement about whether to check gastric residual volume, GRV, when giving feedings into the stomach. Some think an increased GRV increases the risk for aspiration. Other research does not support the practice. Follow your agency policy for checking GRV. Common protocols call for checking GRV every 6 to 8 hours in non-critically ill patients and before each bolus feeding. Other measures to decrease aspiration risk include giving feedings continuously, minimizing the use of sedation, and performing frequent oral suctioning if needed. Pro-motility drugs such as erythromycin or metoclopramide improve gastric emptying and may reduce aspiration risk. Tube position. Obtain X-ray confirmation of newly inserted nasal or orogastric tubes to confirm proper position before starting feedings or medications. Smaller feeding tubes can pass directly into the bronchus on insertion without any obvious respiratory manifestations. Do not rely on the auscultation method to determine between gastric and respiratory or gastric and small bowel placement. Placing a tube under electromagnetic guidance reduces the risk for misplacement associated with blind insertion. Capnography, a direct monitor of breath-to-breath CO level, can determine tube placement in the respiratory tract. However, it still requires X-ray confirmation to verify location before feeding. Maintain proper placement of the tube after starting feedings. To determine if a tube is still in the proper position, mark the exit site of the tube at the time of the initial X-ray and check the tube external length at regular intervals. Consider applying a nasal bridle in patients who try to pull out a tube or for whom taping the nose is difficult. A small bowel tube may dislocate upward into the stomach, or the tube's tip can dislocate upward into the esophagus. If you see a significant increase in the external length, use other bedside tests to help determine whether the tube has become dislocated. These measures include assessing aspirate color and pH. Because each of these measures has limitations, confirm placement with more than one test. If you are checking GVR, watch for unexpected changes in volume. An increase in GVR may indicate displacement of a small intestine tube into the stomach. Site care. Skin care around gastrostomy and jejunostomy tube sites is important because the action of digestive juices irritates the skin. Assess the skin around the feeding tube daily for signs of redness and maceration. Monitor bumper tension and routinely check for pressure injury. To keep the skin clean and dry, initially rinse it with sterile water and dry it. Apply a dressing until the site is healed. After that, wash with mild soap and water. A protective ointment, zinc oxide, petroleum gauze, or a skin barrier, Caraya, stomadhesive, may be used on the skin around the tube. If the skin is irritated, consider using other types of drain or tube pouches. Consult a wound, ostomy, and continence nurse, WOCN, if problems occur. Tube Pedsy. All enteral feedings require routine flushing. Flush feeding tubes in adults with 30 milliliters of warm tap water every 4 hours during continuous feedings or before and after each bolus feeding. Use sterile water in immunocompromised and critically ill patients. Always flush tubes between each medication and after all medications are given. Flush clogged tubes with warm water using a back and forth motion. If that does not work, a pancreatic enzyme solution, an enzymatic declogging kit, or mechanical devices for clearing feeding tubes are options. Misconnection. An enteral feeding misconnection is an inadvertent connection between an enteral feeding system and a non-enteral system, such as an IV line, a peritoneal dialysis catheter, or a tracheostomy tube cuff. With an enteral feeding misconnection, nutritional formula intended for the GI tract is given IV or into the respiratory tract. Severe patient injury and death can result from tubing misconnection. Table 39.13 gives tips to decrease the risk for enteral feeding misconnections. Gerontologic considerations. Enteral nutrition. EN is used in the older patient to improve nutritional status. Because of physiologic changes associated with aging, the older adult is more vulnerable to complications associated with EN, especially fluid and electrolyte imbalances. Complications such as diarrhea can leave the patient dehydrated. Decreased thirst perception or impaired cognitive function decreases the patient's ability to seek needed fluids. With aging, there is an increased risk for glucose intolerance. As a result, the older patient may be more susceptible to hyperglycemia from the high carbohydrate load of some EN formulas. The older adult with compromised cardiovascular function, e.g., heart failure, will have a decreased ability to handle large volumes of formula. If this happens, the patient may need a more concentrated formula, 2.0 calories per milliliter. The older adult has an increased risk for aspiration caused by GERD, delayed gastric emptying, hiatal hernia, or decreased gag reflex. Physical mobility, fine motor movement, and visual system changes associated with aging may contribute to problems managing EN in the home setting. Parenteral nutrition. Parenteral nutrition, PN, is the administration of nutrients directly into the bloodstream. PN is used when the GI tract cannot be used for ingestion, digestion, and absorption of essential nutrients. Table 39.14 lists common reasons for the use of PN. PN is a relatively safe method of providing complete nutritional support. Composition. PN is customized to meet the needs of each patient. The composition is reformulated as the patient's condition changes. This requires you to collaborate with the interprofessional team in delivering PN to the patient. Commercially prepared PN base solutions are available. These base solutions contain dextrose and protein in the form of amino acids. The pharmacy adds prescribed electrolytes, e.g., sodium, potassium chloride, calcium, magnesium phosphate, vitamins, and trace elements, e.g., zinc, copper, chromium, selenium, manganese, to meet the patient's needs. A 3-in-1 or total nutrient admixture containing an IV fat emulsion, dextrose, and amino acids is widely used. Premixed PN solutions require mixing the dextrose and amino acid chambers prior to use. Standard electrolytes are available in some premixed solutions. Multivitamins can be added before use. Calories. Calories in PN mainly come from carbohydrates in the form of dextrose and by fat in the form of fat emulsion. Dextrose 100 to 150 grams per day. 1 gram provides about 3.4 calories, as opposed to oral carbohydrates, which provide 4 calories, has a protein-sparing effect. Providing adequate non-protein calories in the form of glucose and fat allows the use of amino acids for wound healing and not for energy. However, overfeeding can lead to metabolic complications. To minimize these problems, the recommended energy intake is 25 to 30 calories per kilogram per day in a non-obese patient. Fat emulsion solutions of 10%, 20%, and 30% are available. Fat emulsions supply about 1 calorie per milliliter, 10% solution, or 2 calories per milliliter, 20% solution. Fat emulsions primarily contain soybean or safflower triglycerides with egg phospholipids added as an emulsifier. They supply a large number of calories in a small amount of fluid. This is beneficial when the patient is at risk for fluid overload. IV fat emulsions should provide up to 20 to 30% of total calories of PN. Most stable patients receive 1 gram per kilogram per day. The maximum daily lipid dose is 2.5 grams per kilogram per day. Critically ill patients may not tolerate this dose and may receive less than 1 gram per kilogram per day. Serum triglyceride levels are done at the beginning of PN and then closely monitored. Give IV fat emulsions administered separately over 12 hours. The infusion rate should not exceed 0.5 milliliters per kilogram per hour. Fat emulsions are contraindicated in the patient with a problem with fat metabolism, such as hyperlipidemia. They are used cautiously in the patient at risk for fat embolism, e.g., fractured femur, and the patient with an allergy to eggs or soybeans. Protein. Protein is provided at the rate of 1 to 1.5 grams per kilogram per day, depending on the patient's needs. In a nutritionally depleted patient who is under the stress of illness or surgery, protein requirements can exceed 150 grams per day, 2 grams per kilogram per day, to ensure a positive nitrogen balance. Burn and multiple trauma patients may need more than 2 grams per kilogram protein. Protein needs may be lower than 1 gram per kilogram and restricted in those with end-stage renal disease who are not on dialysis. Electrolytes. The exact amount of electrolytes needed depends on the patient's health problem and on serum electrolyte levels. Assess individual requirements daily at the beginning of therapy and then several times a week as the treatment progresses. The following are ranges for average daily electrolyte requirements for adult patients without renal or liver impairment. Sodium, 1 to 2 milliequivalents per kilogram. Potassium, 1 to 2 milliequivalents per kilogram. Magnesium, 8 to 20 milliequivalents. Calcium, 10 to 15 milliequivalents. Phosphate, 20 to 40 millimoles. Trace elements and vitamins. Zinc, copper, manganese, selenium, and chromium are added according to the patient's condition and needs. Monitor levels of these elements. The daily addition of a multivitamin preparation to the PN generally meets the vitamin requirements. The HCP may order additional amounts. Methods of administration. PN is given as central PN or peripheral parenteral nutrition, PPN. Central PN and PPN differ in nutrient content and tonicity, which is measured in milliosmoles, MOSM, the concentration of particles in a fluid. Central parenteral nutrition. Central PN is indicated when long-term support is needed or when the patient has high protein and caloric requirements. We give central PN through a central venous catheter or a peripherally inserted central catheter, PIC, whose tip lies in the superior vena cava. See Chapter 16. Central PN solutions are hypertonic, measuring at least 1,600 milliosmoles per liter. The high glucose content ranges from 20 to 50%. Central PN must be infused in a large central vein so that rapid dilution can occur. The use of a peripheral vein for hypertonic central PN solutions would cause irritation and thrombophlebitis. Peripheral parenteral nutrition. PPN is given through a peripherally inserted catheter or vascular access device into a large vein. PPN is used when 1. Nutritional support is needed for only a short time, 2. Protein and caloric requirements are not high, 3. The risk for a central catheter is too great, or 4. To supplement inadequate oral intake. Compared with central PN, PPN has fewer nutrients. While this makes PPN less hypertonic, still has an osmolality of up to 800 milliosmoles per liter. This increases the risk for phlebitis. Another potential complication is fluid overload. PPN requires large volumes of fluid, which many patients cannot tolerate. Nursing management, parenteral nutrition. Nursing management of patients receiving PN is outlined in Table 39.15 and E-Nursing Care Plan 39.2 available on the website for this chapter. Complications. Complications associated with PN are related to either the catheter or the PN infusion itself. Refeeding syndrome can occur anytime a malnourished patient starts aggressive nutritional support. It is characterized by fluid retention and electrolyte imbalances, hypophosphatemia, hypokalemia, hypomagnesemia. Hypophosphatemia is the hallmark of refeeding syndrome. It is associated with serious outcomes including dysrhythmias, respiratory arrest, and neurologic problems, e.g. paresthesias. Conditions that predispose patients to refeeding syndrome include long-standing malnutrition states, such as chronic alcohol use, vomiting and diarrhea, chemotherapy, and major surgery. Home nutritional support. Home PN or EN is an accepted mode of nutritional therapy for the person who does not need hospitalization but needs continued nutritional support. Some patients successfully receive home therapy for many months, even years. It is important for you to teach the patient and caregiver about catheter or tube care, proper technique in mixing and handling of the solutions and tubing, and side effects and complications. Home nutritional therapies are expensive. Specific criteria must be met for expenses to be reimbursed. The discharge planning team must be involved early to help plan for such issues. Home nutritional support may be a burden for the patient and caregivers and affect quality of life. Tell the family about support groups such as the Olay Foundation that provide peer support and advocacy. Eating disorders. Eating disorders are psychiatric conditions associated with physiologic alterations and risk for death. The manifestations of eating disorders vary across gender, age, socioeconomic status, and race and ethnicity. Patients with eating disorders may be hospitalized for fluid and electrolyte problems, dysrhythmias, and nutritional, endocrine, and metabolic disorders. Menstrual problems may occur in women of childbearing age. Many of the nutritional problems associated with these disorders require you to implement a nutritional plan of care. The three most common types of eating disorders are anorexia nervosa, bulimia nervosa, and binge eating disorder. Binge eating disorder is less severe than bulimia nervosa and anorexia nervosa. Those with binge eating disorder do not have a distorted body image and are often overweight or obese. Eating disorders also occur in some who are health conscious. For example, men with bigorexia or muscle dysmorphia, an extreme concern with becoming more muscular, may use steroids or other drugs to increase muscle mass. They may also use supplements and protein shakes to increase their body weight and mass. The female athlete triad is a syndrome in which eating disorders, amenorrhea, and osteoporosis are present. The triad occurs in females taking part in sports that emphasize leanness and low body weight. Anorexia nervosa. Anorexia nervosa, AN, is characterized by restricting energy intake, difficulties in maintaining an appropriate weight, an intense fear of gaining weight or being fat, and distorted body image. People with AN generally restrict the number of calories and the types of food they eat. Some people exercise compulsively, purge via vomiting and laxatives, and/or binge eat. AN manifests as unwillingness to maintain a healthy weight, refusal to eat, continuous dieting, detailed food rituals, and avoiding social situations. Common assessment findings include signs of malnutrition, extreme thinness, hypothermia, and muscle weakness. Diagnostic studies often show osteopenia or osteoporosis, iron deficiency anemia, high blood urea nitrogen level from marked intravascular volume depletion, and abnormal renal function. A lack of dietary potassium and potassium loss in the urine lead to potassium deficiency. Manifestations of potassium deficiency include muscle weakness, dysrhythmias, and renal failure. Leukopenia, hypoglycemia, and decreased sodium, magnesium, and phosphorus may be present. Treatment involves a combination of nutritional support and psychiatric care. Nutritional care focuses on reaching and maintaining a healthy weight, normal eating patterns, and perception of hunger and satiety. The patient may be hospitalized if there are medical complications that cannot be managed in an outpatient therapy program. Nutritional repletion is closely supervised to ensure consistent and ongoing weight gains. Refeeding syndrome is a rare but serious complication of refeeding programs. The patient may need EN or PN. Improved nutrition, however, is not a cure for AN. The underlying psychiatric issues must be addressed by identifying problematic personal and family interactions, followed by personal and family counseling. Bulimia nervosa, BM, is a disorder characterized by episodes of binge eating with inappropriate compensatory behaviors to avoid weight gain, vomiting, laxative misuse, overexercise. Like those with AN, the person with BN is concerned with body image and often goes to great lengths to conceal abnormal eating habits. They may have normal weight for height, or their weight may fluctuate with binging and purging. There may be signs of frequent vomiting, such as macerated knuckles, swollen salivary glands, broken blood vessels in the eyes, and dental problems. Abnormal laboratory values including hypokalemia, metabolic alkalosis, and increased serum amylase may occur from frequent vomiting. The cause of BN is unclear. It is thought to be similar to that of AN. Some persons with BN report substance use, anxiety, affective disorders, and personality changes. Over time, problems associated with BN become increasingly hard to deal with effectively. A treatment combination of psychologic counseling, i.e., cognitive behavioral therapy, and nutritional counseling is essential. Fluoxetine, Prozac, is the only FDA-approved antidepressant for treating BN. It may not be appropriate for all patients with BN. Education and emotional support for the patient and family are vital. Support groups such as the National Association of Anorexia Nervosa and Associated Disorders, ANAD, are helpful to those affected by these disorders.